Good afternoon, everyone. Am I audible? Okay, let's start today's class. Last day we read general pathologies, cellular injury and adaptations. We almost completed the chapter, except one thing was remaining. It's going to that slide. That is intracellular accumulations. Okay. In intracellular accumulations, last day we read about calcifications. You remember metastatic calcifications and dystrophic calcifications. Last day we read that, and also there are a few intracellular accumulations. I will discuss today. That is this was last slide. This was last time का जो slide है. This time का जो slide है वो ये नहीं है. Just a minute. हम बोले थे ना गाड़ी में आके कि आपको भेजे है आज का बीबीटी. Mail I sent you. Today 2:45. It is. What simple? That was like one plate. नीचे. ऑटो नीचे. Yeah. One side 31. Okay, let's start. Intercellular accumulations, we have discussed about calcification, and there is also proteins accumulations, lipids and endogenous pigments and hyaline change. Okay, in lipids like triglyceride, if there is triglyceride depositions, there is fatty changes in liver, heart, kidney, and if there is cholesterol deposition, there can be atherosclerosis, xanthoma. These are okay. And in endogenous pigments, there are some pigments like lipofuscin, melanin, hemosiderin, etc. Okay, like lipofuscin. Lipofuscin is actually it is of brown color and it is responsible for brown atrophy of liver and heart. Lipofuscin. It causes brown atrophy of liver and heart. Okay. It is seen in aging, protein allergy, malnutrition, and cancer cachexia. Okay. And next endogenous pigments is, first one I said lipofuscin, and next is melanin. We all know melanin, it is, we get it in skin and hair. It is responsible for pigmentation of our skin and hair, and it is only natural occurring endogenous black pigment which is tyrosine derivative. Okay, tyrosine derivative. Tyrosine. Remember this. This is important. Melanin is tyrosine derivative. Okay. And next is hemosiderin. Hemosiderin. Okay. It is golden yellow. The pigment is golden yellow pigment, and it is seen at size of hemorrhage or bruise. Okay. Seen in sites of hemorrhage and bruise, and also seen is, this is very very important, hemochromatosis. Hemochromatosis, that is iron overload. Okay, iron overload. Iron overload in heart, lung, kidney, whatever may be, that is hemochromatosis. So first one is lipofuscin, next one is melanin, and third one is hemosiderin. Though, so these three pigments, just you remember, these are endogenous pigments which are intracellular accumulations in case of cell injury. Okay. And next one is hyaline change. Next one is hyaline change. Okay. In hyaline change, we'll see there may be intracellular or extracellular hyaline accumulation. We just remember few points about intracellular accumulations, intracellular hyaline accumulations. Okay. Such as Mallory bodies. Mallory bodies. It is hyaline accumulation in case of liver injury. Okay. In case of liver disease, liver injury, we'll get Mallory bodies. Okay. And one thing you remember, Russell body. One thing you remember, that is Russell body. It is seen in multiple myeloma. So Mallory bodies we found in liver injury, and Russell body we found in multiple myeloma. And another thing, last day I already told about that, that is Jenker's degeneration or Jenker's hyaline change. Jenker degeneration, last day I called about that. Jenker degeneration is a true necrosis, that is coagulative necrosis, and it affecting skeletal muscles and cardiac muscles. Most commonly it is affecting skeletal muscles, and less commonly it is affecting cardiac muscles. Okay, last day I told about that. And it is mostly seen during acute infections like typhoid. Okay. Okay. In last year, 2024, suppose I think 2024 also. The question came from here, Mallory bodies. Okay. I'll come later. Next. Okay. Today we'll start inflammation. Okay. New chapter. Cell injury and adaptations almost complete. Today we'll start inflammation. See, inflammation, it is the response of blood vessels and cells to an injurious stimulus. Okay. And it can be acute inflammation and chronic inflammation. Now remember that there are four cardinal signs. Total there is 5 signs. Okay. Now four cardinal signs, that is redness, swelling, and pallor, dullor. That signs are given by Celsus. Okay. And the fifth sign, that is punctulacia or loss of function, that is given by virtue. Okay. Rubor, pallor, dullor, tumor. These four signs given by Celsus, and fifth signs, that is loss of function or punctulacia, it is by virtue. This can come in MCQ also. So try to remember this one, okay? Okay. Next. Next is just said na, acute inflammation and chronic inflammation. So we have to remember the stages of acute inflammation, and there are two stages, that is vascular events and cellular events. Okay. In vascular changes, first we will see vasoconstriction. Okay. That is vasoconstriction. It is the first change in the blood vessels which is transient in nature. It is the first change which is transient in nature. Okay. And it is clinically responsible for blanching seen immediately after injury. So it is responsible for blanching seen immediately after injury. This is the first change, and it is transient in nature. These 3 points you remember. Okay. For MCQ. This is the first change, and this is transient in nature, and it is responsible for the blanching seen immediately after injury. Okay. Next, moving in vasodilatation. So first is vasoconstriction, and next is vasodilatation. That is increased blood flow leading to redness and sensation of warmth. Okay. That means rubor and color. Okay. Rubor and color. Next is increased. First one, vasoconstriction is of transient, and vasodilatation, it is for longer duration. Okay. Longer duration. It is for longer duration. And next one is increased vascular permeability. That is the hallmark of acute inflammation. Hallmark of acute inflammation. Remember, increased vascular permeability, it is the hallmark of acute inflammation, and it is caused by separation of endothelial cells resulting in movement of fluid, cells and proteins out of the blood vessels. Okay, that is called exudate. Okay, and it is caused by endothelial gaps, endothelial injury and endothelial cell retraction. Okay. Remember, in increased vascular permeability, there are permeability in this mechanism. There are three steps. Okay, endothelial gaps formation, and after that endothelial injury and endothelial cell retraction. This endothelial gap formation, it is immediate transient response. Okay, immediate transient response. MCQ comes from these points. Okay, increased vascular permeability is an important topic in inflammation. Okay, these three you remember: endothelial gaps formation, and after that endothelial injury, and after that endothelial cell retraction. Okay, so formation of endothelial gaps, it is immediate transient response. Okay, it is reversible. And next is endothelial injury. Okay, endothelial injury, it is fast, it is the fast process, and it also may be long lived. Okay, and third one is endothelial cell retraction. Just remember, this is a delayed and prolonged process. This is endothelial cell retraction is delayed and prolonged process. Okay, and remember, the exudate is protein rich fluid. Okay, whereas transudate is protein poor. Next slide. So we have completed vascular events. Now we have came into cellular events. Okay, in cellular events, the steps will go through margination, rolling, adhesions, diapedesis, and chemotaxis. Okay. Now first one is margination. In marginations, we'll see there is movement of leukocytes toward the periphery of the blood vessels. Okay. So what is margination? Movement of leukocytes towards the periphery of blood vessels. Margination. Next is rolling. It is the process of transient adhesions of leukocytes with the endothelial cells. Okay. And remember, it is very, very important. Selectins are chiefly responsible for this process. So, what is the protein responsible for rolling process? Selectin. Okay, selectin is chiefly responsible for this process. Okay. Next is adhesion. Adhesion. This is firm attachment of leukocytes to endothelial cells, and integrins are responsible for this process. Okay. For rolling, selectin, and for adhesion, integrins. Remember. Okay. And next one is diapedesis or transmigration. Transmargination. Sorry, this is actually typing error. That will be transmigration. Okay, this is typing error. That will be transmigration. I was right. Transmigration or diapedesis. Everyone please note, this is a typing error. That will be transmigration or diapedesis. Okay. So here what happening? Here migration of leukocytes through endothelium. Okay, migrations of leukocytes through endothelium. Neutrophils predominate in the inflammatory inflammate during first 6 to 24 hours and replaced by monocytes in next 24 to 48 hours. And one thing you remember, PCAM1 or CD31 is the molecule responsible for diabetes. PCAM1, the full form is platelet endothelial cell adhesion molecule, or CD31 molecule is responsible for transmigration or diabetes. Remember this one, very important MCQ for MCQ. Last time the MCQ came as the steps of the margination, steps of the cellular events. One by one you have to arrange the steps. That was the pattern of MCQ. A, B, C, D steps were written: margination, rolling, adhesions, and you have to choose the correct options. What are the actual correct steps one by one? Okay. So next is chemotaxis. So after transmigration or diabetes, next is chemotaxis. Chemotaxis, one thing remember, very important, it is unidirectional movement. Okay, it is unidirectional movement, very important. So unidirectional movement of leukocytes towards bacteria is in response to certain chemicals, that is chemotaxis. Okay. And next is opsonization. Opsonization. In opsonization, there is coating of bacteria so that they can be easily engulfed by the white blood cells, and chemicals causing opsonization is called opsonins. Like what are the opsonins? C3b, IgG, fibrinogen and CRP. That's why in acute inflammation, we give test to the patients CRP. We see in acute inflammation, we see what? CRP is increasing in acute inflammation. So it is one kind of opsonin. Okay. Next is phagocytosis. We all know that phagocytosis is a process by which bacteria are killed or eaten up by the neutrophils or white blood cells. Okay. And lysosomes are the important organisms for phagocytosis. Okay. Remember, lysosomes are the important organisms for phagocytosis. So in phagocytosis, it is of three steps, characterized by three steps. First one is recognition and attachment, next one is engulfment, and third one is killing and degradation. Recognition and attachment, there is the particles to be ingested by leukocytes are recognized by receptors present on the surface of the WBCs. Okay, and the receptors like Cavenger's receptors and Mann's receptors, these are the receptors. Just remember it. Cavenger receptors, Mann's receptors. Okay, these are the receptors. And next is engulfment. In engulfment, there is formation of phagolysosome. There is formation of phagolysosome. Okay, and this is due to fusion of the lysosomes and the phagosome, that is phagolysosome. Okay, inside the leukocytes, this phagolysosome, it is followed by degranulations of leukocytes. Okay, and next step is killing and degradation. This is very important, killing and degradation. Coming into next slides about killing and degradation. Next slide is important. That is, there are two types of bacterial killing. One is oxygen dependent method, that is the main method, and another one is oxygen independent method. Okay, see, oxygen dependent method is the main method, and Another one is oxygen independent method. In oxygen dependent method, these are the enzymes. See, these are the enzymes. Okay, 1, 2, 3, 4, 5. These are the enzymes which play roles in this process. You just remember 1, 2, 3. These are most important. Okay. There is production of microbicidal reactive oxygen species within phagocytic vesicles by the following mechanism, and this mechanism is respiratory burst mechanism. Okay. Respiratory burst mechanism. Okay. And the final step in the microbial killing, that is due to reactive oxygen species. Okay. These are reactive oxygen species, shortly we called ROS. Okay. Reactive oxygen species, that is called respiratory burst. Okay. Now this process. Okay. See, O2 get converted into superoxide ion by NADPH enzyme. Okay. NADPH oxidase. Okay. So O2 gets superoxide anion by NADPH oxidase, and then the superoxide anion got transformed into hydrogen peroxidase by superoxide dismutase. Here, superoxide dismutase. So first enzyme NADPH C1, here is 1. C2 superoxide desmotase. So then hydrogen peroxidized, it can break into water, or by myeloperoxidase enzyme it can turn into hypochlorite ion. Okay, this hypochlorite ion is actually help in microbicidal healing. Sorry. Reactive. This is the reactive oxygen species. Okay. Okay. See, you just remember these three enzymes. These are very, very important. Okay. These are very, very important. NADPH oxidase and superoxide dismutase and myeloperoxidase. Okay. 1, 2, 3. You just remember these three enzymes, and you can also remember these one also, but these are sufficient. Okay. Just remember these three. Okay. This phenomena is happening inside the neutrophil. When neutrophil engulf the bacteria inside the neutrophil, this phagolysis, this incident is occurring, and the whole process is called respiratory burst mechanism. Okay. Next. See what I have told in last slide. Hypochlorite causes most active bacterial activity. This is the last compound what I told na. it causes microbicidal activity. So it causes most active bacterial activity. That is halogenation and lipid peroxidation of bacterial walls, and finally bacterial killing. Okay, and defective in NADPH oxidase activity and respiratory burst resulted in chronic granulomatous disease. Okay, this is an important topic for MCQ. Chronic granulomatous disease. Okay, this is an X-linked recessive disorder and hereditary disorder, and it is important NBT test is used for diagnosis. NBT test what? Nitroblue tetrazolium test. Okay. What is NBT test? This is nitroblue tetrazolium test. Okay. See, as the name indicates, the test uses nitroblue tetrazoline dye, which is a colorless compound, which on uh, on presence of NADPH oxidase, it the dye reduces and precipitates into blue-black deposits. Okay, which is also called final product जो है, which is forzaman. Sorry, formazan. Formazan. So whenever the dye changes in color, it means that NADPase is present and neutrophil can efficiently produce reactive oxygen species and efficiently kill the microorganism. And if there is NADPase oxidase absent, then in absence of NADPase oxidase, the dye cannot turn into blue black color, and instead of that it remains in its original color, okay, which is yellowish color, and that indicates NBT test is negative test. So in case of chronic granulomatous disease, there is NADP oxidase defect, on NADP oxidase activity defective. So there is NBT test negative, and in normal person there is NBT test positive. Okay. And one thing you just remember, there is also two tests. I'm writing. There is also two tests. One is cytochrome C. Cytochrome C reduction assay, and another one is dihydrorhodamine test. Okay. Dihydrorhodamine test. See, this is the test which is quantitative test, and NBT test and DHR dihydro, these two tests are qualitative. Okay. Now moving into next slide. See, Till now we read oxygen dependent system. Okay, now it is oxygen independent system. Okay, oxygen dependent system was the main. Okay, and oxygen independent system we also read that one. Okay, in oxygen independent system there is various enzymes and proteins. Okay, like lysozyme, lactoferrin, and bacterial permeability increasing protein, major basic protein, defensin, and cathelicidin. Okay, now lysozyme. Lysozyme can cause hydrolysis of glycopeptide of bacteria. Okay, lactoferrin. You just remember in oxygen independent system, these are the enzymes. Okay, just remember the name of the enzymes and proteins. Okay, like lysozyme, lactoferrin, MBP, defensin, cathelicidins. Okay, and lactoferrin, what is lactoferrin? This is an iron binding protein, we know. And bacterial permeability increasing protein, this is also a protein. And major basic protein, this is present in eosinophils and toxic to parasites. Okay. And next is defensins. Defensins is arginine rich peptides that is toxic to microbes. Okay. And cathelicidins, it is important, very, very important. Antimicrobial proteins in the neutrophils and other cells. These are highly effective against Mycobacterium tuberculosis. So, Mycobacterium tuberculosis, this is highly effective against Mycobacterium tuberculosis. See one thing, the synthesis of antimicrobial protein, that is cathelicidins. Okay, this is stimulated by 125 dehydroxy vitamin D. Okay, and the importance of this non-skeletal effect of vitamin D. So this is synthesized by vitamin D. This is stimulated by vitamin D. So this vitamin D deficiency can increase the chances of tubercular infections. And this protein, it is the having antimicrobial roles against Mycobacterium tuberculosis. So if these proteins is not synthesized properly, there will be easily tuberculosis affections. So vitamin D deficiency, if there is high chances of tuberculosis infections. Okay, just remember it. This is important. If tough questions, if question will be tough, then this type of questions also can come. Okay. Next. Next is some important chemical mediators. Okay. So two types of mediator we know. One is cellular and one is plasma mediator. Okay. Cellular mediator, in cellular mediator, there is two types, preformed and newly synthesized. Preformed are histamine, serotonin and lysosomal enzyme. And newly synthesized are prostaglandins, leukotrienes, cytokines, nitric oxide and platelet activating factor. Okay. And in plasma, the cellular mediators which are synthesized in liver, those are complement system, clotting system and kinin system. Okay. Coming into later slide. See, preformed cellular mediators. Okay. There is also typing error. Preformed cellular mediators. So first one is histamine. Histamine, it is formed from histidine. Okay, histidine, that is an amino acid. So histamine, it is formed from histidine. and mast cell as the richest source of histamine. Remember it. And histamine causes vasodilatation. Very, very important. Histamine causes vasodilatations and also vasoconstriction in large arteries. This is the exception, vasoconstriction in large arteries. Okay. And histamine causes increased vascular permeability and bronchoconstriction. So histamines, what are doing it? It causes vasodilatations, increased vascular permeability and bronchoconstriction. See, vasodilatation but bronchoconstriction. Okay. It is most important chemical mediator in acute inflammation. Acute. It is most important chemical mediator in acute inflammation. Okay. Next one is serotonin. Okay. Serotonin. So serotonin, from where it is derivative is, it is platelets are richest source. Okay. Platelets are richest source of serotonin. So from where it is formed? Platelets. And also present in enterochromaffin cells. Okay. And the function is like histamine. Okay. Next in lysosomal enzymes. Present of lysosomes of neutrophils and monocytes, and it contains two type of granules, primary granules which is also called azurophilic granules, and secondary granules which is called specific granules. Okay. And neutrophils also have tertiary granules, or which is also called C particles, which contain gelatinase and acid hydrolases. Okay. See, primary azurophilic granules, it require high level of agonist to be released extracellularly. And primary azurophilic granules secrete the enzymes like reading. Primary azurophilic granules, it secretes enzymes like myeloperoxidase enzyme and acid hydrolase, defensin, phospholipase A2. So these are the enzymes secreted by primary azurophilic granules. Okay. Next is secondary granules, the or specific granules. Specific, secondary. It secretes lysosome, lactoferrin, alkaline phosphatase, and important type 4 collagenase. Okay. And these also like primary granules, these also secretes phospholipase A2. Both secretes phospholipase A2. So specific granules secrete lysozyme, lactoferrin, alkaline phosphatase, and type 4 collagenase. Okay. Write down it. So next. Next is newly synthesized chemical mediators. Okay. Newly synthesized chemical mediators, we just we just saw that nitric oxide, cytokines, leukotrienes, prostaglandins, these are there. Okay. So first one is nitric oxide. Okay. Nitric oxide, it is formed from L-arginine. Okay, it is formed from L-arginine with the help of nitric oxide synthesis enzyme. Okay, nitric oxide formed from L-arginine with the help of nitric oxide synthesis enzyme. See, it is a potent vasodilatation. Histamine was also vasodilatation and bronchoconstriction, and nitric oxide, this is also vasodilatation and reduction of platelet aggregation and endogenous regular recruitment of leukocytes, also poses microbicidal actions by acting as free radicals. Next one is cytokines. Interleukins, interferons, tumor necrosis factor. These are the tumor necrosis factor alpha. These are the most important among the interleukin. These are the most important among the interleukin 1 and tumor necrosis factor alpha. Okay. So tumor necrosis factor alpha and interleukin, same problem is happening again. See, interleukin 1 and tumor necrosis factor. Okay, these are most important cytokines. Okay, interleukin 1 and tumor necrosis factor. These both are most important among the cytokines. Okay, they causes acute phase reactions like fever, increased sleep, decreased appetite, neutropenia. Okay, now interleukin 1 is the most important cytokine responsible for the systemic effect of inflammation. Same thing it is told. Okay. Interleukin 10 and transforming growth factor beta possesses anti-inflammatory action. So these are inflammatory, but interleukin 10 and transforming growth factor beta, TGF beta, that is anti-inflammatory. Remember, by writing except, MCQ can come like this. Okay, all are inflammatory except. So transforming growth factor beta, it is the most common fibrogenic agent, but it is anti-inflammatory in action. It causes fibrosis in lung, liver, kidney in chronic inflammation. So in acute it is not in anti-inflammatory, but in chronic inflammation it causes fibrosis. Okay, acute में नहीं है, in chronic inflammation it causes fibrosis in lung, liver and kidney. Okay. See, one thing that is in fever. Okay, in fever, what are the cytokines? That is pyrogenic cytokines. Pyrogenic cytokines. What are the pyrogenic cytokines in fevers? What are the cytokines get released? Okay, so lipopolysaccharide. This one, Nesis, interleukin 1, tumor necrosis factor alpha, and interleukin 6. Note down that these are the cytokines which released in fever. Okay, lipopolysaccharide, interleukin 1, tumor necrosis factor alpha, and interleukin 6. And there is also most important, this is prostaglandin E2. This is most important chemical mediator in like interleukin 1. This is also most important, PGE2, and interference also. Okay. So note down, these are the pyrogenic cytokines, lipopolysaccharides, interleukin 1, interleukin 6, human necrosis factor alpha, and PGE2, prostaglandin E2, and interference. Among them, PGE2, human necrosis factor alpha, interleukin 1 and 6. These are very, very important for MCQ. Okay. See, one thing, you remember interleukin 8, it is a member of interleukin 1 family, okay, but does not causes fever. Remember it as it is exception, because we just read interleukin 1 causes fever. And I am saying interleukin 8, it is member of interleukin 1 family, but does not causes fever. So interleukin 8 is exception. Okay. So interleukin 8 doesn't causes fever. Just remember it. Okay. So now next one is arachidonic acid metabolites. Okay. So, in arachidonic acid metabolites, there is 20 fatty acid containing 4 double bonds. Okay. There is two types of pathway. One is COX pathway, one is LOX pathway. Okay. Are coming. See, one is COX pathway and one is LOX pathway. So in cellular mediators, we read nitric oxide, then we read cytokine. Next, we will read arachidonic acid metabolites. Okay. In arachidonic acid metabolites, in this pathway, we will see there is from membrane phospholipids, by phospholipase A2, there is arachidonic acid formation, and from arachidonic acid formations, there is LOX pathway and COX pathway. Okay. In LOX pathway, there is lipoxin. These derivatives, lipoxins, these are anti-inflammatory. Just remember this, I am saying the points which are only important for MCQ. Okay. You have already read this in your UG level. So I am just highlighting the points which are important for MCQ. Okay. So this lipoxin A4 and B4, these are anti-inflammatory. Remember it. Okay. And leukotriene B4, it is chemotactic. Okay. And this is chemotactic for neutrophil chemotactic. Okay. And leukotriene C4 D4E4, these three substances are known as slow reacting substance of anaphylaxis. Okay. That's why it causes increase in permeability and vasoconstriction. Increase in permeability and vasoconstriction. Okay. And if we go through COX pathway, cyclooxygenase pathway, then prostaglandin G2, it will first synthese, and from PGG to PGH2 it comes. Okay. And from PGH2 there is PGI2, PGD2E2 and F2 alpha and thromboxane A2. Okay. So you remember PGI2, prostaglandin I2, it is formed in blood vessels. It inhibits platelet aggregation and causes vasodilatation. In MCQ, it can comes like what are the vasodilatations except options. In options, there may be histamine, there may be serotonin, okay, there may be PGI2, and there may be another one which is vasoconstriction, which causes vasoconstriction. So that type of MCQ can come from here, okay. So PGI2, remember it causes vasodilatation. Next is PGD2E2 and F2 alpha. Okay. This causes pain, fever and increase in vascular permeability. Okay. So for fever, the responsible derivatives are PGD2, E2 and F2 alpha. Okay. Next, PGD2 also increases mucus production also. Okay. Next is thromboxane A2. Thromboxane A2, it is formed in platelet and it causes platelet aggregation and vasoconstriction. So, if in MCQ it comes like what are the these are the vasodilators except, and it is written histamine, PGI2, serotonin and thromboxane A2. So except will be thromboxane A2 because thromboxane A2 is a vasoconstrictor. Okay. So it causes platelet aggregation and vasoconstrictions and also a smooth muscle cell mitogen. Okay. So arachidonic pathway, it is completed. Next is, see, this COX pathway. Okay, this COX pathway, it is important for pain also. The painkillers, the painkillers in modern medicine which are used, this also doing this also work in COX pathway. Okay, remember it. Next, mediators present in plasma. Plasma mediators. So complement system. Complement system, it consists of 20 complement proteins. Okay. These are numbered from C1 to C9 and these follows 4 pathways. Okay. One is classic activation pathway. Next one is mannose binding pathway and last one is alternative activation pathway and sorry, final one is terminal pathway. You just remember the pathway and the terminal pathway is the common pathway. Okay. And critical step in the functioning of the complement system is activation of C3 activation. Okay. This is C3 is the most abundant complement. You remember for MCQ, C3 is the most abundant complement. Okay. Next, it is important for MCQ is IgM and IgG. These are responsible for activation of classical pathway. And IgA is responsible for alternative pathway. Okay. Last slide. We have seen the pathway. Okay. Classic classical pathway, mannose binding or lactic activation pathway, alternative pathway, terminal pathway. Four pathways. Okay. And so IgM and IgG, these are responsible for activation of classical pathway, and IgA, this is for alternative pathway. Remember it. Okay. And deficiency of C2 complement is most common complement deficiency and results in streptococcal septicemia and lupus-like syndrome in children. Okay. Lupus-like syndrome, SLE, DLE. Okay. So deficiency of C2 is most common complement deficiency and most abundant complement what? C3. So remember, most abundant complement C3 and deficiency of C2 is most common complement deficiency and it results in streptococcal septicemia and SLE or DLE like symptoms in children. Okay. And C1 inhibitor blocks binding of C1 to immune complex. So excessive, its deficiency causes excessive complement activation. This forms the basis of hereditary angioneuritic edema, which is a non-pitting edema. Okay. Next is, in which complement deficiency there is which disease. Okay. So in C1 esterase inhibitor deficiency, there is hereditary angioneuritic edema, I have just told. And if there is C1, C2, C4 deficiency, there is SLE, collagen vascular disorder. Okay. In C5 to C8 deficiency, there is bacterial infections with Neisseria and toxoplasmosis. Okay. And in C9 deficiency, there is no particular disease. And in DAF and CD59 deficiency, there is paroxysmal nocturnal hemoglobinemia. Okay. So DAF means decay accelerating factor. Okay. Decay accelerating factor. Okay. So in DAF and CD59 deficiency, there is PNH. Okay. And CD46 or factor H and I deficiency, there is atypical or non-epidemic hemolytic uremic syndrome. This is also called GUS. Okay. So next is clotting system. Okay. See, in clotting system, there is two pathway. One is intrinsic pathway and one is extrinsic pathway. Okay. Intrinsic pathway, when blood comes into touch with injured endothelial cell or blood comes in touch with subendothelial exposed collagen or blood comes into touch with activated platelets, then factor 12 got activated. Okay. Factor 12, we all know factor 12 is also known as coagulation factor, uh, coagulation factor or contact factor or Hegman factor. Okay. So intrinsic pathway is triggered by factor 12. Remember it. Factor 12 triggered intrinsic pathway. Okay. And liver is producing a lot of coagulation factor, releasing in circulation all the time. Okay. The first event here we'll see we will come this P kallikrein, this kinin system coming later. Okay. This is kinin system coming later. You just start from here. Okay. Factor 12 got activated. A means activated. Okay, these all A are activated. So factor 12 got activated by kallikrein. Okay. So first event here is factor 12 is converted into active factor 12. Okay. In this, in where it is occurring, it is occurring in the site of the where platelets are activated or where endothelial cell is activated. Okay. So all these are capability to activate the Hegman factor. Okay. So now factor 12 got activated, and this activated factor 12, this helps in factor 11 to activated factor 11. Okay. So factor 11 got activated by factor activated, sorry, 1 second. Factor 11 get activated by factor 12. Okay. Next, factor 9 get activated by factor 11A and calcium. Okay. Next is factor 9. This from factor 9, factor 10 gets activated by factor 9. Activated factor 9. Factor 10 get activated by activated factor 9 and phospholipid and factor 8 and calcium. Okay. These steps important. Phospholipid, factor 8 and calcium. Okay. And see, both are from here, it is common pathway, intrinsic pathway and extrinsic pathway. In extrinsic pathway, there is factor 3, we all know this is tissue factor. Factor 3 is also called tissue factor. It was produced from injured surface, from tissue surface. Okay, injured tissue surface. And here from factor 3, factor 7 got activated. Okay. So factor 3 to factor 7 to activated factor 7 and activated factor 7 to factor 10. Okay. So activated factor 10. So prothrombin, from prothrombin to thrombin, it helps activated factor 10. So activated factor 10 helps from prothrombin to thrombin formation. Okay. And from fibrinogen to fibrin formation, thrombin helps. Okay. And thrombin also, but thrombin also got also ये thrombin stabilizing factor. Okay. It also called factor 13. This one. So thrombin gets converted into factor 13 by thrombin stabilizing factor. Okay. And from that activated thrombin stabilizing factor, there is also fibrin formation. Okay. Now this fibrin formation helps in clot formation. So these are the coagulation cascade. Okay. So from first, see, kinin system. Now going to kinin system. See, in kinin system, it is initiated by factor 12 and from factor 12 to activated factor 12. Okay. These activated factor 12 helps from pre-kallikrein to kallikrein. I am showing. See, pre-kallikrein to pre-kallikrein to kallikrein by factor 12. Next, kininogen got activated into kinin or bradykinin. So from kininogen to kinin, it is by kallikrein. Okay. So kallikrein helps in kininogen to kinin. Kinin is also known as bradykinin. Bradykinin is a contraction. Bradykinin, what are the functions of bradykinin? So it is the contractor of smooth muscles, okay, and it causes pain and dilatation of the venules, okay. So remember, bradykinin or kinin, it is a con it is a contractor of smooth muscles, okay. Remember it from coagulation cascade, deficiency of clotting factors 8 and 9, it causes hemophilia A and B respectively. For factor 8, hemophilia A, and 9, factor 9, hemophilia B. Okay. And in both hemophilia A and B, there is bleeding time is normal, prothrombin time is normal, thrombin time is normal, but prolonged PTT. Okay. Remember it, prolonged PTT. PTT is prolonged. All are normal, but PTT is prolonged. Now, morphological pattern of inflammations. Okay. So, there is serous inflammation, fibrinous inflammation, scatteral, purulent. These are types. Okay. In serous inflammations, there is presence of outpouring of the fluid, like effusion is fluid, accumulation is cavity. So there is effusion, fluid accumulation in cavity, like pleural effusion. Next is fibrinous inflammation. Okay. In fibrinous inflammations, there is deposition of fibrin in extracellular space due to large vascular leaks. Okay. Like characteristics of inflammation in body cavity linings, like meninges or pericardium. So if there is pericarditis or meningitis, okay, meningitis or pericarditis, in case of there will be fibrinous inflammations, okay. And next one is catarrhal inflammations, okay. In catarrhal inflammations, there is epithelial surface inflammation, okay, that causes increased mucus secretions, mucus secretion, and it is the commonest type of inflammations. Remember, catarrhal inflammation is the commonest type of inflammation, and which is seen in common cold infection. So it is seen in common cold infections, okay. And last one is purulent inflammations. Purulent exudate is made of necrotic cells, neutrophils, and edema fluid, okay. Like abscess, abscess is localized collections of purulent inflammatory tissue, okay. So purulent inflammation, example is abscess. So serous effusion, this is pleural effusion, fibrinous effusion, meningitis, pericarditis, catarrhal inflammation in common cold infections, and purulent inflammation, it is abscess. Okay. Next, we will go through chronic inflammation. Okay. In chronic inflammation is characterized by infiltration of mononuclear cells, okay, including macrophage, lymphocytes, plasma cells. These are, okay. Tissue destructions, infiltration of mononuclear cells, tissue destructions, and healing by replacement of damaged tissue via angiogenesis and fibrosis, okay. Remember, important for MCQ, it is Macrophage is the dominant cells. Okay. And tissue destruction is the hallmark of chronic inflammation. Like as granuloma formation is also hallmark of chronic inflammations. Okay. Tissue destruction and granuloma formations, both we found in chronic inflammations. Okay. Granuloma. So in acute inflammation, we never found granuloma formations. Okay. In chronic, we found granuloma formations. Okay. And infection is the commonest cause of chronic inflammations. So infection is the commonest cause of chronic inflammations. Okay. And from where macrophage derived? From stem cells of bone marrow. It give rises to monoblast, and from monoblast there is monocyte, and a number of monocyte collages into macrophage. Okay. So remember it, granuloma formation never occur in acute inflammation. It is always in chronic inflammation, and tissue destruction is the hallmark of chronic inflammations. Okay. Next, see, these are the different type of tissue, type of macrophage we found in different sites. So these are the different type of macrophages we found in different sites. Okay, like in liver we found Cooper cells. In central nervous system we found microglia. Okay, in bone osteoclast. In lung there is alveolar macrophages cell. Okay, and or also known as dust cell. Remember, alveolar macrophage also known as dust cell. Okay, and in connective tissue there is histiocyte. In placenta there is Hubber cells. Last 2 or 3 years before a question come from Hubber cells. Okay, Hubber cells we found in placenta. Okay, in spleen there is littoral cells or step cells. Okay, in kidney, mesangial cells. In synovium, type A lining cells. These all are important for MCQ. Single liners MCQ. These all are important. Okay. Remember it. Next is granulomatous inflammations. Okay. See, granulomatous inflammation. Chronic inflammation characterized by formation of granuloma. I have already told repeatedly. It is an aggregation of what is granuloma, and it is aggregation of macrophages surrounded by a collar of mononuclear cells, principally lymphocytes. Okay. Macrophages may form epithelioid cells, or they may fuse to form a bigger cell called giant cell. Giant cell. Okay, the example of giant cells were coming in later slides. Okay, so common conditions resulting in granuloma formations with important features are tuberculosis, sarcoidosis. Remember these are the common conditions which are resulting in granuloma formations. Okay, so tuberculosis, sarcoidosis, brucellosis, cat scratch disease, and cat scratch disease, syphilis, and lymphogranuloma inguinal, leprosy, and IBD. Okay. See, in tuberculosis, we found caseating necrosis, caseating granuloma, and in sarcoidosis, remember it is non-caseating granuloma. It is important. In sarcoidosis, it is non-caseating granuloma. Okay. And these are the diseases where we getting granuloma formation. Remember this. And in cat scratch disease, there is stellate sepate ganglia or round granuloma we found. Okay. So question may come in MCQs. Stellate sepate or round granuloma is found in which disease? So cat scratch disease. Okay. In syphilis, there is gamma granuloma. Okay. Gametous ulcer also there. That's why syphilis called gametous ulcer. There is gamma granuloma. Okay. And lymphogranuloma inguinale, leprosy, IBD. These are also the disease we found granuloma. So I was telling later the giant cells example. So these are the examples of giant cells like Langerhans giant cells we found in Langerhans giant cell we found in TB. Okay. This is a horseshoe pattern giant cell and next is foreign body giant cell. This is granuloma formed by foreign body like sutures, cells, etc. Next one is Teuton giant cells. Okay. In Teuton giant cells, we found Teuton giant cells in xanthomas, pathocrasis, xanthogranulomatous inflammation, and dermatofibroma. Okay, these are the conditions we found Teuton giant cells. And physiological giant cells we seen in osteoclast, syncytotrophoblast, and megakaryocyte. Okay. And what in pimply giant cells we seen in measles. This is very important for MCQ. Okay. In measles, we found what in pimply giant cells. Okay. In measles. And this is also important for MCQ Langerhans giant cells in TB, tuberculosis. Okay. Tumor giant cells, this is important. Reed Sternberg giant cells. This is owl sepid. Okay. Owl sepid giant cell. This is seen in Hodgkin's lymphoma. So Reed Sternberg giant cells. This is also MCQ, important for MCQ. This is seen in Hodgkin's lymphoma. Owl sepid giant cell is called Reed Sternberg giant cells. And Asop cells, we all know it is found in rheumatic fever or rheumatic carditis. Asop cells, this is also important for MCQ. We found in rheumatic fever or rheumatic carditis. So whatever the point I am highlighted, these are all important for MCQ. Okay, remember it. Next one is type of cells. Okay. So there are three types of cells: permanent cells, stable cells, and labile cells. Okay. So permanent cells, cells of body which never divide. Okay. Like neurons, skeletal muscle fibers, and cardiac myocytes. Okay. And stable cells. In stable cells, there is low rate of multiplication, usually present in G0 phase. Okay, that is cells of proximal tubule of kidney, PCT. Okay, so stable cells we found in PCT, proximal tubule of kidney, and labile cells. These cells can regenerate throughout the life. Okay, like hematopoietic cell, that is stem cell. Okay, hematopoietic stem cell and cells of skin and GI mucosa. Okay, so these are labile cells. Okay, so remember three types of cells: permanent cells, stable cells, and labile cells. Okay, if this hematopoietic cell, it is very important. This is stem cells. It can regenerate throughout the life. Okay. Next is wound healing. So, process of regeneration of the damaged tissue by cells of the same type and replacement of the lost tissue with connective tissue. Okay. Now, regeneration. What is regeneration? It is proliferation of cells and tissues to replace lost structures. Okay. And repair, what is repair? It consists of a combination of regeneration and transformation by the deposition of collagen. So regeneration, what is regeneration? In regeneration, there is proliferation of cells and tissues to replace. So in regeneration, there is loss structure replacement. Okay. But in repair, there is combination of regeneration and also scar formation. Okay. By the collagen deposition. Okay. Next is stages of wound healing. Okay. So there is four stages: hemostasis phase, inflammatory phase, proliferative phase, and remodeling or maturation phase. Okay. Hemostasis phase. This is the very quick steps or early steps. Okay. This is the early steps, the process of the wound being closed by clotting in this step. Okay. This started when blood leaks out of the body and the blood vessels constrict to the restricted, the blood vessels constrict to restrict the blood flow. Okay. So when the blood vessels constrict to restrict the blood flow, so it is hemostasis phase. Okay. So here in this stage there is fibrin formation and there is release of prothrombin or procoagulants. Okay. And in inflammatory phase, there is it begins after the hemostasis phase, after the injury, when injured blood vessels leaks transudate. Okay. After that, after the injury, it is inflammatory phase. Okay. And during this inflammatory phase, there is damaged cells, pathogens, bacteria, which are aggregated. Okay. In proliferative phase, there is tissue proliferation. Okay. See, in this proliferative phase, if there is granulation tissue is pink in color, that means there is healthy healing. Okay. And if there is dark granulation, pink means healthy healing. Okay. And if there is dark granulation tissue, that that means that is sign of infection. Okay. That is sign of infection. Okay. Or poor healing or poor perfusions. Okay. And finally, epithelial cell resurface the injury. Okay. See, last one is remodeling or maturation phase. Okay. Here, collagen is remodeled from type 3 to type 1. So, collagen type 3 to type 1 collagen. It is very, very important. Last time also the MCQ came from type 3 collagen to type 1 collagen. This process is in which phase of wound healing. Okay, so this is in remodeling or maturation phase. Remember it. So this collagen formation, collagen 3 to collagen type 1 collagen, this occurs in maturation phase. Okay, or remodeling phase. Both are same. Okay, and generally this phase begins about 21 days after injury. Begins about 21 days after injury and can continue for a year or more. Okay, can continue for a year or more. Okay. So next is healing by primary intention. Okay. Healing by first or primary intention. So the healing of a clean uninfected wound is called healing by first or primary intention healing or primary union healing. See, clean uninfected wound. Okay, not infected. See, these are the phenomena in which are occurring. Okay, just remember it. Day 0, there is presence of blood clot, and day 1, there is neutrophilic infiltration with blood clot, and day 2, there is neutrophil plus blood clot plus continuous thin epithelial layer. This is important. Okay. Day 2, there is neutrophil plus blood clot plus continuous thin epithelial layer. Okay. Day 3, there is macrophages replace neutrophils, appearance of granulation tissue, and type 3 collagen deposition begins. This is important. Type 3 collagen deposition begins in which day? Day 3. Okay. Just begins, okay? Just begins, but do not breach the incision. Just begins. Remember it. And day 5, there is abundant granulation tissue, collagen tissue, fibrils breach the incision. So in day 3, breach started, okay? And day 5, the breach is completed. So collagen tissue, fibrils breach the incision, and this is important. Neovascularization is the maximum on which day? Day 5. Okay. So neovascularization is the maximum in day 5, and full epithelial thickness with surface keratinization. So full epithelial thickness with surface keratinization we found in day 5. Okay. And end of the second week, there is accumulation of collagen, fibroblast proliferation. Okay. So accumulation of collagen and fibroblastic proliferation, this is occurring in end of the second week. Okay. And in 1 month, there is replacement of collagen type 3 with collagen type 1. What I have told in remodeling phase. Okay. Very important. Replacement of collagen type 3 with collagen type 1. Just now I have told it begins about 21 days after the inflammation, and it got completely 1 year or more to complete. Okay. So replacement of collagen type 3 with collagen type 1, it is 1 month. Okay. And it is due to action of collagenase enzyme. Collagenase enzyme. Okay. And end of 1 month, there is scar formations. Okay. End of 1 month, there is scar formation. See, granulation tissue, what I have underlined there, fibroblasts, small blood vessels, and inflammatory cells. So, granulation tissue, what makes granulation tissue? Fibroblast, not blood vessels, and chronic inflammatory cells like macrophages and lymphocytes. And it is the hallmark of fibrogenic repair. Okay. And neovascularization is maximum on 5th day. I have highlighted there. Okay. And the chief cell responsible for scar contraction is myofibroblast. The chief cell responsible for scar contraction is myofibroblast. Next is healing by secondary intention. So we read primary intention, now it is secondary intention. Okay. So during secondary infection, secondary healing by secondary intention, inflammatory response being more intense, granulation tissue is abundant and a large scar is formed. Okay. So healing by secondary intention, there is large scar is formed and the scar decreases in size after some time, which is called scar contraction. Okay. And remember, this is important, wound strength. So wound strength is 10% after 1 week. Okay. Increases rapidly during next 4 weeks and becomes 70% at the end of third month and will never reach 100%. So wound strength will never reach 100%. It is 10% after 1 week, 70% at the end of third month. Remember it. It is important. It comes in MCQ also. Okay. And predominant collagen of adult skin is type 1. So type 1 collagen is predominant collagen for adult skin. Okay. But in early granulation tissue, it is type 3 and type 1. So in early granulation tissue, there is predominant collagen is type 3 and type 1. Okay. And zinc is a cofactor. Zinc, very, very important. Zinc is a cofactor in collagenase. That's why in zinc deficiency, it is associated with impaired wound healing. So in zinc deficiency, associated with impaired healing, because zinc is a cofactor in collagenase. So collagen production, zinc also helps. And if there is zinc deficiency, it is associated with impaired healing. Okay. Next is infections are the most common cause of impaired wound healing. So like zinc deficiency, infections are also the most common cause of impaired wound healing. Okay. There is one thing, it is not given in slide. See, we have red keloid and hypertrophic scar. Okay. So if there is excessive connective tissue, so if there is excessive connective tissue, there is one, that is granulation tissue, and another one may be excess collagen. Okay. So if there excessive granulation tissue, also known as proud flesh, also known as proud flesh. Okay. And this excess collagen, okay, this excess collagen, it leads to two types. It may be the scar localized to the wound, if there is scar localized, or maybe the scar extend beyond the injury site. Both can happen. See, if the scar is localized to the wound, it is called hypertrophic scar. So, if the scar is localized, it is called hypertrophic scar. So, raised scar remains within the confines of the wound, that is hypertrophic scar, and it usually develops within 4 weeks after a trauma. So, usually it develops within 4 weeks after trauma. And these called keloid. So what is the difference between hypertrophic scar and keloid? Hypertrophic scar is localized, and if the scar is extend beyond injury site, that is keloid. Okay. And in keloid, this is beyond the original margin, and it is generally predisposed to Afro-Americans. Okay, it is predisposed to Afro-Americans. Okay, and the commonest site. Okay, commonest site is sternum. So for keloid, the commonest site is sternum. Okay. Without sternum, there are also earlobe, face, neck. These are also the site for keloid. Okay, but most commonest site for keloid is sternum. Remember it. Okay, and it usually develops after 3 months of an injury. This is 4 weeks, and this is 3 months of injury. Okay. This is the difference between hypertrophic scar and keloid. And sternum is the most common site for keloid. Okay. So next is stem cell. Okay. Stem cell. A cell with a unique capacity to produce unaltered daughter cells and to generate specialized cell types. Okay. That is stem cells. You know. And there is types of stem cells in potency. Okay, potency is used to indicate the cell's ability to differentiate into specialized cell types. Okay, so this can be classified like totipotent stem cells, multipotent stem cells, oligopotent, or unipotent or monopotent stem cells. Okay, so coming to totipotent stem cells. Okay, it can form an entire organism autonomously. Okay, example of totipotent stem cells is zygote. So only zygote. It came in questions. Okay, example of totipotent stem cell. Zygote is totipotent stem cell. Zygote, fertilized egg. Okay, and multipotent. Multipotent means it can form multiple cell lineage, but cannot form all of the body's cell lineage. So it can form multiple cell lineage. Okay, like hematopoietic stem cell. So Hematopoietic stem cells. It is example of multipotent stem cell. Next is oligopotent. Okay. So it can form more than one cell. That's why oligo. Okay. More than one cell lineage it can form. Okay. Example is neurons. Neuron stem cells. Okay. And last one is unipotent or monopotent stem cells. Okay. It can form a single differentiated cell lineage. Okay. So it can form a single differentiated cell lineage. Example is spermatogonia. So these are the examples of stem cells. Next is there are few cells which are localized. Okay, the special sites of stem cells. Okay, the name of the cells, locations, and functions. Okay, so oval cells we found in panels of hearing of the lip. Sorry, it is mistake typing error. That will be hearing. HERR, hearing of the lip. Canals of hearing of the liver, and the function is forming hepatocyte cells and biliary cells. Okay. Next is satellite stem cells. Okay. Satellite cells found in basal lamina of myotubules. Okay. And the function is differentiate into myocyte after an injury. Next is limbus cells. Okay. Limbus cells we found in canals of xylem. Okay. And it functions is stem cells for the cornea. So limbus cell is stem cell of cornea. Okay. Next is ito cells. Ito cells we found in liver. In liver, subendothelial space of Disse we found ito cells and it store vitamin E. Okay. And next is Paneth cells. Paneth cells we found in bottom of crypts of intestine and it host defense against microorganisms. Okay. See, this is the MCQ. Inflammation chapter completed. Okay. So, cellular injury and adaptation completed on last day, and today inflammation chapter is completed. Two chapters are completed, and this is the MCQ in last year that was came. So, answer please. Anyone? Last day we read about this one, this MCQ. Okay. Sorry. Anyone answer?
Third, ma'am, third.
Three. Okay. Correct. Okay. Increased red index we found in chronic bronchitis. Mallory Hyalin, I just said today in first slide, it is in alcoholic liver injury. Reed-Sternberg giant cells, it is Hodgkin lymphoma and caseous necrosis in tuberculosis. So it is 3. Okay. Last year the question came. And question number 2, what will be the answer? What are the steps?
Second,
First one is, what are the steps here? Margination. Okay. Then rolling. Okay. Rolling and addition. Okay. Two. Good. Two. So first one is margination. Next one is rolling and adhesions. Then transmigration. Then chemotaxis.
Transmigration.
Then phagocytosis. Okay. And last one, question number 3. Which phase of wound healing is characterized by replacement of type 3 collagen by stronger type 1 collagen? I just said.
remodeling.
I just told.
Remodeling.
Four. Right. Remodeling. Good. Okay. You are listening. Okay. Good. Okay. Okay. Next, we're moving to next chapter. Okay. Hemodynamics. Okay. Next chapter. And 2 chapters. Hemodynamics. Plus 15 minutes. Okay. Okay. New chapters. Okay. Mix. Hemodynamics অনেক টপিক আছে যেমন ইডিমা শকিং মিন্স একটা স্টিমাটা কমপ্লিট করব Am I audible?
Yes.
Audible?
Yes, ma'am.
Anyone please reply. Am I audible?
Yes, ma'am.
Yes, ma'am.
सुनाई नहीं दे रहा है क्या? रिस्पॉन्स नहीं कर रहा है. हाँ. Okay. So hemodynamics, neoplasia, genetics. These 3 chapters are remaining. Okay. And next class we'll complete general pathology and immunity. Okay. Neoplasia, immunity, genetics, and hemodynamics. These 4 chapters are remaining. Today we'll discuss about edema. Okay. In hemodynamics, we'll discuss edema. Okay. Okay. See, edema in a normal blood vessels like capillary, there are 2 forces. Okay. And the 2 forces, one is hydrostatic pressure and another one is colloidal osmotic pressure. Okay. Hydrostatic pressure causes fluid movement from inside the vessel to outside. So inside to outside, that is hydrostatic pressure. Okay. And the colloidal osmotic pressure, that is due to albumin. That is due to albumin protein. So colloidal osmotic pressure is responsible for the reverse movement. Okay. जैसे just as hydrostatic pressure from inside to outside, and the reverse is colloidal osmotic pressure. Okay. In edema, the excessive interstitial fluid can be either exudate or transudate, or exudative or transudative. Okay. So transudative Transudate is protein rich fluid. Okay. Transudative fluid is protein rich fluid and cell poor. Cell less है, protein ज़्यादा. Okay. Cell is much, cellular component is much and protein less. So protein poor, sorry, printing mistake है. Protein poor and ठीक है, सॉरी, ठीक है. Transudate is protein poor and cell poor fluid and exudate is protein rich and cell rich fluid. Okay. Transudate is protein poor and cell poor fluid. Exudate is protein rich and cell rich fluid. Okay. And the causes and conditions associated with edema are due to increased hydrostatic pressure. What are the disease? Okay, what are the disease or what are the disease conditions due to increased hydrostatic pressure? So congestive heart failure or congestive cardiac failure, ascites, venous obstruction due to thrombosis of physical inactivity and arterial dilatation. Just remember congestive heart failure or congestive cardiac failure, ascites and venous obstruction due to thrombosis. Okay. These three you remember. Okay. And due to decreased colloidal osmotic pressure, liver cirrhosis, malnutrition or protein losing enteropathy. Okay. These are the conditions which are due to decreased colloidal osmotic pressure. Okay. Next is lymphedema or lymphatic, due to lymphatic obstruction. If there is edema, that is lymphedema. That can be after surgery or after neoplasia or inflammations. Okay. And next one is sodium retention. This is due to increased salt intake, decreased renal perfusion or increased RASS activity. Okay. Inflammation, it is acute or chronic, and severe generalized edema is called anasarca. So severe generalized edema is called anasarca. Now there is differentiation between hyperemia and congestion. Okay. See, in hyperemia, it is active process due to arteriolar dilatation, and congestion is passive process. So hyperemia is active process and congestion is passive process. It is due to arteriolar dilatation. It is due to impaired venous outflow. Here edema is absent. In congestion, edema is present. Okay. In hyperemia, there is red color of the tissues, and in congestion, there is blue red color, bluish red. Okay. And hyperemia, it is seen in inflammations, and in congestion, seen in right heart failure or congestive cardiac failure, portal vein obstructions in cirrhosis. Okay. So in right heart failure, we see congestion and in portal venous obstruction in liver cirrhosis. Next is hemostasis. Okay. In hemostasis, there is it is a sequence of events. Hemostasis, we just read that there is involvement of vascular endothelium, platelets and clotting systems. So in platelets and clotting systems, there we have to read prothrombin time and thrombin time, normal bleeding time, okay, and activated partial thromboblastin time. So this one is prothrombin time, PT. Okay, this is used to monitor functioning of the extrinsic and the common coagulation pathways. Okay, we have read today coagulation pathway. So prothrombin time, it is due to functioning of extrinsic and the common coagulation pathway. Okay. And normal prothrombin time is 12 to 16 seconds. 12 to 16 seconds. Coagulation prothrombin time, it is prolonged in deficiency of factor 7, 10, 5, 2 and 1. Okay. And if anyone is taking oral anticoagulants like warfarin. Okay. So warfarin therapy, it is also prolonged. So functioning of the extrinsic and common pathway. We have read today in extrinsic pathway there is factor 7 and factor 10 there was. Okay. So remember it, factor 7, 10, 5, 1, 2. Okay. Next is APTT, activated partial thromboplastin time. It is used to monitor the functioning of intrinsic and the common coagulation pathway. Okay. So PT, prothrombin time was extrinsic and common coagulation, and APTT, it was for intrinsic and common coagulation pathway. Okay. So PT is extrinsic and common, and APTT is intrinsic and common. Okay. Normal APTT is 26 to 34 seconds. Okay. A relatively rare cause of prolonged APTT is presence of antibodies against coagulation plasma protein called inhibitors. Okay. It can be seen due to following reasons: hemophilia A and hemophilia B patients receiving clotting factors to control their bleeding episodes, and in case of pregnancy, autoimmune disease and malignancies. Okay. And prolonged in deficiency of factor 12, 11, 9, 3 and 10 and 5. Okay. Prothrombin and fibrinogen deficiency and heparin therapy. Okay. So in warfarin therapy, PT prolonged, and in heparin therapy, APTT prolonged. Okay. In heparin therapy, APTT prolonged, and in warfarin therapy, PT prolonged. Okay. Next is thrombin time. It is used for testing the conversion of fibrinogen into fibrins and depends on adequate fibrinogen levels. And normal thrombin time is 12 to 14 seconds. Okay. And it is elevated in afibrinogenemia, dysfibrinogenemia, heparin-like inhibitors, and disseminated intravascular coagulation. So where fibrin synthesis is hampered, there is thrombin time is elevated or increasing. Okay, remember it. And in heparin therapy and disseminated intravascular coagulations. Thrombin is a procoagulant, but thrombin thrombomodulin complex, it is an anticoagulant. Okay, remember thrombin is a procoagulant, but thrombin thrombomodulin complex, which is an anticoagulant, and thrombomodulin is produced by all endothelial cells except those in the cerebral microcirculations. Except, remember, thrombomodulin is produced by all endothelial cells except cerebral microcirculations. Next is bleeding time. It is the time taken for a standardized skin puncture to stop bleeding. It tests the ability of blood vessels to constrict and platelets to form a hemostatic plug. Normal bleeding time is 3 to 10 minutes, and in Duke method it is 2 to 5 minutes. Remember, if questions come like in Duke methods, it is the answer will be 2 to 5 minutes, and normally if any method is not written, then normally the answer will be 3 to 10 minutes. Okay. And bleeding time elevated in thrombocytopenia and thrombocytopenia, where quantitative value of platelet is compromised, there it is thrombocytopenia, and where qualitative value is compromised, that is thrombocytopenia. Okay. So in platelet disorder, so this much is for today. In next class, we will conclude whole general pathology. Okay. Thank you for today. And if anyone having any questions or query, you can ask. If no one having any doubt, so concluding today's class. Thank you everyone.